This is PA Diver. Welcome to your home version of Common Ear Problems, which allows you to go through this PowerPoint at your own pace. So let's get started. Most patients come in complaining of either an earache or ear pain. This should make you think of many differentials. This PowerPoint will guide you through multiple differentials, etiologies, as well as treatments. Please take a few minutes as far as to review your ear pain objectives. This allows you to look at a patient complaining of ear pain, developing a differential diagnosis, formulating your diagnosis based on history and physical exam findings, using non-pharmacological or pharmacological treatment, recognize the signs and symptoms, life-threatening HENT disease, and given a history, physical exam, and diagnostic findings, determine the indications for referral. The history often only provides a starting point. Ear pain is a very common complaint in primary care practice, both in pediatric and adult populations. In a random sample of 411 adults in Finland, 7.5% of men and 23.4% of women had experienced ear pain that was not associated with infection in the previous 6 months. The character and severity of pain may be a helpful feature when making your diagnosis. Most local causes of ear pain have a characteristic physical finding, while most cases of referred pain will have a normal ear exam. The pain of acute otitis media is generally severe, often interfering with sleep. In contrast, the pain of eustachian tube dysfunction is usually modest or mild, often described by a patient as feeling of discomfort or even fullness. Referred pain from inflammation of a nerve is frequently described by patients as burning, knife-like, or even electrical sensation. It may even be provoked by light touch. Earwax, cerumen, uncommonly causes ear pain. If earwax is present, it must be removed to exclude the possibility that true pathology lies behind the eardrum as in otitis media. Earaches can be caused by a variety of otologic problems, but external otitis and acute otitis media are the most common. Differentiation of the two should be apparent by pneumatic otoscopy. Pain out of proportion to the physical exam findings may be due to herpes zoster oticus, especially when vesicles appear in the ear canal or on the concha. Persistent pain and discharge from the ear suggest osteomyelitis of the skull base or even cancer, and patients with these complaints should be referred for specialty evaluation. Non-otological causes of ear pain are numerous. The sensory innervation of the ear is derived from multiple nerves like the trigeminal, facial, glossopharyngeal, vagal, and upper cervical nerves. Because of this rich innervation, referred otology is quite frequent. Infections of the ear and associated structures can involve both the middle and the external ear, including the skin, cartilage, periosteum, ear canal, and tympanic and mastoid cavities. Both viruses and bacteria are known causes of these infections, some of which result in significant morbidity if not treated appropriately. Infections involving the structures of the external ear are often difficult to differentiate from non-infectious inflammatory conditions with similar clinical manifestations. PAs should consider inflammatory disorders as possible causes of external ear irritation, particularly in the absence of local or regional adenopathy. Aside from the more noticeable causes of inflammation such as trauma, insect bite, and overexposure to sunlight or extreme cold, the differential diagnosis should include less common conditions such as autoimmune disorders. The cause of ear pain is localized and can be divided into outer ear problems and inner ear problems. Outer ear problems are located external to the tympanic membrane and include otitis externa, ear canal foreign bodies, earwax, and mastoiditis. Occasionally, a furuncle may cause ear pain. Inner ear problems are located at the tympanic membrane or deep to it and include acute otitis media, the single most common cause of ear pain, and eustachian tube dysfunction. Injuries to the tympanic membrane, which can occur from barotrauma or from direct trauma to the ear, can also cause ear pain. As you do your physical exam, try to do it the same way each time, looking externally to internally. Externally, you want to look at the ear or pinna to see if there's any changes in shape, see if there's a color change or position, or if you notice any tenderness or swelling. As you look at the mastoid, look for erythema, swelling, tenderness, or pain to touch. As you start your internal exam, again look externally to internally. Start with the canal and look for any skin changes, foreign body, discharge, debris, or wax. As you look at the tympanic membrane, look at all aspects anterior, posteriorly, superiorly, inferiorly of the malleolus. Check for color changes, retraction, perforations, and or discharge. As you move on behind the eardrum, check for fluid behind the drum, any red bits, which could be a tumor, granulation, or blood. If it's white, it could be a cholesteatoma. Physical exam, you need to know what the norms are. Here is a slide looking at the eardrum normal landmarks. Be familiar with these. Review these so that you know what you're looking at when you do your physical exam. This is a representation of a normal TM. Consider the malleolus as an arrow pointing in the forward direction. The normal tympanic membrane should appear pearly gray in color, have a light reflex, generally concave with visible malleolus. As you can see, you have a positive arrow sign and multiple circles to give you the norms. Auricular cellulitis is an infection of the skin overlying the external ear and typically follows minor local trauma. It presents as a typical sign and symptom of cellulitis, with tenderness, erythema or redness, swelling, and warmth of the external ear, particularly the lobule, but without apparent involvement of the ear canal or the inner structures. Once you diagnose a patient with auricular cellulitis, you need to know how to treat it. This consists of warm compresses and oral antibiotics such as cephalexin or Keflex, or dicloxacillin that are active against typical skin and soft tissue pathogens, specifically Staph aureus and streptococci. IV antibiotics such as first-generation cephalosporin, cefzolizin, or penicillinase-resistant penicillin, nafcillin, occasionally are needed for more severe cases. You need to consider MRSA if either risk factors or failure of therapy point to this organism. Perichondritis is an infection of the perichondrium of the auricular cartilage. Typically follows local trauma, such as piercings, burns, or lacerations. Occasionally, when the infection spreads down to the cartilage of the pinna itself, patients may develop chondritis. The infection may closely resemble auricular cellulitis, with erythema, swelling, and extreme tenderness of the pinna, although the lobule is less often involved in perichondritis. The most common pathogens are Pseudomonas and Staph aureus, although other gram-negative and gram-positive organisms occasionally are involved. As a PA, you need to know your limitations. Perichondritis is one of those diagnoses that needs to be sent forward to a referral to an ear, nose, and throat specialist or surgeon. Treatment consists of systemic antibiotics, active against both Pseudomonas and Staph aureus, an anti-pseudomonal penicillin such as piperacillin or a combination of penicillinase-resistant penicillin, and an anti-pseudomonal quinolone such as nafcillin plus ciprofloxacin is typically used. Incision and drainage may be helpful for culture for resolution of the infection, which often takes weeks. When perichondritis fails to respond to adequate antimicrobial therapy, you may need to consider a non-infectious inflammatory etiology such as relapsing polychondritis. Ramsay-Hunt syndrome, or herpes zoster oticus, is caused by the infection of the cranial nerve ganglia. This is most likely due to the virus that causes chickenpox. You'll more likely see this in older patients. Clinically, pain out of proportion to the physical exam findings and painful herpetic lesions on the ear and the external auditory canal are consistent with herpes zoster oticus. In some severe cases, there's facial nerve paralysis or Bell's palsy, which is cranial nerve 7 paralysis. You also have hearing loss or balance disorders. Differentially, persistent pain and discharge from the ear suggest osteomyelitis of the skull base or cancer. So that needs to be also in your differential. Non-odontologic cases of otalgia are numerous. The sensory innervation of the ears are derived from the trigeminal, facial, glossopharyngeal, vagal, and the upper cervical nerves. Because of this rich innervation, referred otalgia is quite frequent. Bell's palsy can progress to a severe, complete facial nerve paralysis. So treatment needs to be initiated very quickly using prednisone 60 milligrams per day, PO tapered over 3 weeks, using an antiviral such as valcyclovir, Valtrex 1000 milligrams PO Q8 hours times 7 days, adding on analgesics such as ibuprofen, naproxen, or narcotics for the pain, and a referral to an otolaryngologist for these patients. If the patient has problems where they are not able to afford their medications, you may have to use acyclovir, which is generic, but it's going to be requiring the patient to take the medication much more often, up to 5 times a day. Furunculosis is a furuncle which is well circumscribed, painful, suppurative inflammatory nodule involving a hair follicle that usually arises from pre-existing folliculitis. A furuncle can occur at any site that contains hair follicles, especially in the regions that are subject to friction and maceration, such as the face, neck, axilla, groin, thighs, and buttocks. The lesions may extend into the dermis and the subcutaneous tissue and often serves as a nidus for cellulitis and skin abscess. Furunculosis can develop in the outer third of the ear canal since there is a large amount of hair in that area. Staph aureus is usually the pathogen. Clinically, when you put an ear speculum into the ear, you'll note that there is swelling that may be fluctuant. It's also tender when you pull on the tragus. Treatment consists of IND, or incision and drainage, of that fluctuant area. Systemic antibiotics are necessary if cellulitis or systemic symptoms are noted. The antibiotic needs to be an anti-staphylococcal penicillin such as dicloxacillin or cephalexin. As a PA, you need to identify the alarm symptoms. PA should consider and exclude the following 4 serious diagnoses in any patient with ear pain. Referred pain for malignancy usually has been present for some time. In a series of patients with referred pain, the pain between onset of ear pain and the tumor diagnosis range from 4 to 21 months, with a mean of 7.5 months. These patients are typically older. The mean age at diagnosis in this series was 55.8 years. Necrotizing or malignant external otitis is a rare condition which external otitis progresses to invade the temporal bone and adjacent structures. It is almost exclusively due to infection with Pseudomonas. The condition occurs in immune-compromised patients, especially older diabetic patients, and should be considered when the patient does not respond promptly to treatment for otitis externa. Consider temporal arteritis when a patient is over the age of 50, reports acute or subacute onset of headache, pain in the temporal area, or scalp tenderness. A relatively specific symptom of temporal arteritis is jaw claudication, which is defined as pain in the proximal jaw near the TMJ, brought on or aggravated by a brief period of chewing and relieved by resting the jaw. A patient may describe this as ear pain, but careful questioning should clarify the location of the pain. Temporal arteritis rarely presents with true ear pain. Prompt diagnosis of temporal arteritis is essential because it can cause sudden and permanent blindness if untreated. Mastoiditis generally occurs in children when otitis media spreads to the mastoid air cells behind the ear. A typical presentation is fever with post-auricular swelling, tenderness, and erythema, which can sometimes push the ear forward by a mass effect. Patients often report becoming ill several weeks earlier, improving but then developing fever and signs of local infection. This condition must be promptly recognized and treated because the infection may spread to nearby critical structures such as the temporal bone, meninges, and the brain. Ear pain is one of the most common reasons for an office visit in primary care. Otitis media, when you look at statistics, is the third most common and the 11th in the reasons among more than 500,000 patient problems. In addition, patients come in with earwax, otitis media, otitis externa are also ranked up in the top 50 for the visits. The cause of ear pain may be in or near the ear. So as a PA, you need to consider that these areas are innervated by different neural pathways, such as 7th, 9th, and 10th cranial nerve. The external ear is primarily got the fibers from the facial nerve or 7th cranial nerve. And parts of the external auditory canal also receives innervation from the auricular branch of the vagus nerve, called Arnold's nerve, which contains all fibers from the 7th, 9th, and 10th nerve. The middle ear receives its neural innervation through branches of the glossopharyngeal nerve or cranial nerve 9. This nerve also innervates the throat and tongue, which is common for the throat pain and referred from the middle ear or to the middle ear. Otitis media is primarily in children, usually the ages of 6 months to 3 years, but it does also affect adults. You need to make sure that you diagnose this and treat with amoxicillin at high doses, usually 90 to 100 milligrams per kilogram per day. As you start seeing patients in the clinic, you'll see more and more earwax than you care to admit. The wax is produced in the outer half of the ear canal and migrates outwards along the ear canal skin. A lot of times patients use different objects to try to get the wax out, but this causes more of an impaction. This wax impaction can cause hearing loss, pain, ringing of the ears, vertigo, even a chronic cough, but usually it doesn't have a discharge. Anytime that you have something that causes immediate type loss of hearing, most cases someone has stuck something in the ear, such as a crayon or a foreign object, and you need to definitely look to see in the ear canal and remove that foreign body. Cotton tip applicators are definitely not your friend. They cause more trauma and more impaction of earwax than any other thing that we use. A lot of times we treat this symptomatically. We use a topical medication. We can use these sodium bicarbonate drops, which might be better if helping if you wind up disintegrating the wax, but it can cause dryness of the canal or irritation. You can lubricate it as far as with olive oil or mineral oil, and then you can use what's called a syringing technique, which is half warm water and half hydrogen peroxide, which slowly irrigates that ear, pointing it upwards, not at the tympanic membrane, because that can cause nystagmus and cause the patient to have vertigo and throw up. If you have organic material, avoid water because this can cause swelling, such as vegetables or anything that would be organic. As a PA, you need to know when to refer to an otolaryngologist. Anyone that has had known tympanic membrane perforation, a previous ear surgery that's going to require microsuction, only hearing in one ear, syringing irrigation fails, if it causes pain or vertigo, or if there's hearing loss persist after wax removal. Otitis externa usually results from the combination of heat and retained moisture, with desquamation and maceration of the epithelium of the outer ear canal. The disease exists in several forms: localized, diffuse, chronic, and invasive. Heat, humidity, and the loss of the protection cerumen lead to excessive moisture and elevation of the pH in the ear canal, which in turn leads to skin maceration and irritation. All forms are predominantly bacterial in origin, with Pseudomonas and Staph aureus being the most common. Clinically, otitis externa often starts with itching and progresses to severe pain, which is usually elicited by manipulation of the pinna or tragus. The onset of pain is generally accompanied by development of an erythematous, swollen ear canal, often with scant white, clumpy discharge leading to ear fullness or plugged sensation and hearing loss. This is most common during summer months. This is usually caused by the breakdown of the protective barrier normally formed by the skin and cerumen. The most common pathogens that we note are Pseudomonas and Staph aureus. Treatment consists of cleaning the canal to remove debris and enhance the activity of topical therapeutic agents, usually hypertonic saline or mixtures of alcohol and acetic acid. Inflammation can also be decreased by adding glucocorticoids to the treatment regimens or by using Burrow solution aluminum acetate in water. Antibiotics are most effective when given topically. Otic mixtures provide adequate pathogen coverage. These preparations usually combine neomycin with polymyxin, with or without a glucocorticoid. There is a strong label warning: aminoglycosides such as neomycin should be avoided if the tympanic membrane is ruptured or it is not visualized. This is considered ototoxic. Do not use it if you cannot see the TM. Systemic antimicrobial agents typically are reserved for severe disease or infections in immune-compromised hosts. Invasive otitis externa, also known as malignant or necrotizing otitis externa, is an aggressive and potentially life-threatening disease that occurs predominantly in elderly diabetic patients and other immune-compromised persons. The disease begins in the external canal as a soft tissue infection that progresses slowly over weeks to months and often is difficult to distinguish from a severe case of chronic otitis externa because of the presence of purulent otorrhea and erythematous swollen ear and external canal. Severe, deep-seated pain, frequently out of proportion to the findings on the examination, is often noted and can help differentiate invasive from chronic otitis externa. The characteristic findings on examination is granulation tissue in the posterior inferior wall of the external canal near the junction of the bone and cartilage. If left unchecked, the infection can migrate to the base of the skull, resulting in skull-base osteomyelitis, and onward to the meninges and brain, with a high mortality rate. Cranial nerve involvement is seen occasionally, with the facial nerve usually affected first and most often. Malignant otitis externa requires an immediate referral to otolaryngology. Some patients are hospitalized and we must use systemic antibiotics against Pseudomonas. Pseudomonas is by far the most common offender, although Staph aureus, Staphylococcus epidermidis, Aspergillus, some gram-negative bacteria also have been known to associated with this disease. In all cases, refer to otolaryngology. The patient will be required hospitalization so the external ear canal can be cleansed and a biopsy taken of the granulated tissue within the canal or of the deeper tissues obtained for culture of the offending organisms. IV antibiotic therapy should be given for a prolonged course, usually 6 to 8 weeks, and direct specifically toward the recovered pathogen. Aggressive glycemic control in diabetics is important not only for effective treatment but also prevention of reoccurrence. Infections of the middle ear structures, such as otitis media, is an inflammatory condition of the middle ear that results from dysfunction of the eustachian tube in association with a number of illnesses, including URIs and chronic rhinosinusitis. The inflammatory response in these conditions leads to the development of a sterile transudate within the middle ear and the mastoid cavities. Infection may occur if bacteria or viruses from the nasopharynx contaminate this fluid, producing an acute or sometimes chronic illness. Some of the increased risk factors for otitis media, such as being in daycare, passive exposure to smokers, being formula fed, and family history. Acute otitis media typically follows a viral URI. The causative virus is most common RSV, influenza virus, rhinovirus, and enterovirus can themselves cause subsequent acute otitis media. More often, they predispose the patient to bacterial otitis media. Studies using trypanocentesis have consistently found strep pneumoniae to be the most important bacterial cause, isolated in about 35% of the cases. H. flu for the non-typical strains, and MCAT also are common bacterial causes of acute otitis media. And MRSA is now also an increasing concern. Fluid in the middle ear is typically demonstrated or confirmed with pneumatic otoscopy. In the absence of fluid, the TM moves visibly with the application of positive and negative pressure, but this movement is dampened when fluid is present. With bacterial infection, the TM can also be erythematous, bulging, or retracted, and occasionally can perforate spontaneously. There has been considerable debate on the usefulness of antibiotics for treatment of acute otitis media. A higher proportion of treated than untreated patients are free of illness 3 to 5 days after diagnosis. The difficulty of predicting which patients will benefit from antibiotic therapy has led to different approaches. In the Netherlands, for instance, physicians typically manage acute otitis media with initial observation, administering anti-inflammatory agents for aggressive pain management and reserving antibiotics for high-risk patients, patients with complicated disease, or patients whose condition does not improve after 48 to 72 hours. In contrast, many experts in the United States continue to recommend antibiotic therapy for children less than 6 months old in light of the higher frequency of secondary complications in this young and functionally immune-compromised population. In the United States, children cannot go back to daycare until they have been either put on antibiotics or fever-free for 24 to 48 hours. Despite the resistance to penicillin, and amoxicillin is roughly 1/4 of strep pneumoniae isolates and 1/3 of H. flu isolates in nearly all MCAT isolates. Outcome studies continue to find that amoxicillin is as successful as any other agent and remains the drug of first choice in recommendations from multiple sources. Surgical management of acute otitis media or otitis media with effusion is largely dependent on development of complications. Tympanocentesis and placement of tympanostomy tubes can play a role for refractory cases. Antibiotic therapy or myringotomy with insertion of the tympanostomy tubes, typically reserved for patients who has bilateral effusion, has persisted for at least 3 months, is associated with significant bilateral hearing loss. With this conservative approach and the application of strict diagnostic criteria for acute otitis media and otitis media with effusion, it's estimated that 6.8 million courses of antibiotics could be avoided each year in the United States. Chronic infection of the middle ear and mastoid generally develops as a consequence of recurrent acute otitis media, although it may follow other diseases and trauma. Perforation of the tympanic membrane is usually present. The bacteriology of the chronic otitis media differs from that of the acute otitis media. Common organisms include Pseudomonas, Proteus species, Staphylococcus aureus, and mixed anaerobic infections. The clinical hallmark of chronic otitis media is purulent ear discharge. Drainage may be continuous or intermittent, with increased severity during upper respiratory tract infections or following water exposure. Pain is uncommon except during acute exacerbations. Conductive hearing loss results from the destruction of the tympanic membrane or a siccular chain, or both. The medical treatment of chronic otitis media includes regular removal of infected debris, use of earplugs to protect against water exposure, and topical antibiotic drops. Oral antibiotics can be added on, like Cipro 500 milligrams twice daily, which will require treatment for at least 6 weeks. The most definitive management for these cases is going to be surgical. When an infection results in acute rupture of the tympanic membrane, treatment consists of a combination of oral and topical antibiotics, as well as preventing water entry into the ear canal. Ototopic drugs that have low acidity and low ototoxicity, such as ofloxacin, are preferred. Acidic antiseptic agents, as well as topical agents containing aminoglycosides or alcohol, should be avoided when the middle ear space is open. Although there are no definitive data showing that preparations such as polymyxin neomycin drops can cause hearing loss in these circumstances, there is an explicit manufacturer warning not to use neomycin polymyxin B hydrocortisone for non-intact tympanic membrane. In most cases, the ruptured tympanic membrane will heal. The perforation permits drainage of the middle ear abscess and relieves increased middle ear pressure. With the relief of the middle ear pressure, the extensively vascularized tympanic membrane usually heals quickly, sealing the perforation within days. Persistent subjective hearing loss following resolution of the infection should be followed up with an audiogram and otolaryngological consultation. Chronic perforations may occur. A chronically infected middle ear or mastoid may result in persistent suppurative drainage. Patients with perforation that persists for more than 6 weeks or longer, with or without suppurative drainage, should be referred to an otolaryngologist for further management. As you do your physical exam of the tympanic membrane, make sure you look superiorly and inferiorly of the tympanic membrane. The area that's considered unsafe is usually known as the attic. A rupture or perforation of the eardrum can lead to conductive hearing loss. Collapse of retraction of the eardrum can cause conductive hearing loss and or a cholesteatoma in that area. In the general area below, which is the pars flaccida, This is considered safe and is primarily ruptured due to chronic ear infections. Serous otitis media is primarily caused from prolonged eustachian tube dysfunction, which results in a negative middle ear pressure, may cause a transudation of fluid. This condition, known as serous otitis media, is especially common in children because the eustachian tubes are narrower and more horizontal in orientation than those in adults. Serous otitis media is less common in adults, in whom it usually occurs after an upper respiratory tract infection. In serous otitis media with effusion, fluid is present in the middle ear for an extended period and the absence of signs and symptoms of infection. In general, acute effusions are self-limited. Most resolve in 2 to 4 weeks. In some cases, however, in particular after an episode of acute otitis media, effusions can persist for months. These chronic effusions are often associated with significant hearing loss in the affected ear. The majority of cases of otitis media with effusion resolve spontaneously within 3 months without antibiotic therapy. Recommendations for follow-up and referral. Anytime that you have an adult patient with a serous otitis media, particularly if it's unilateral and outside the setting of an upper respiratory tract infection, you need to think nasopharyngeal mass, and you need to refer to an otolaryngologist to rule this out. Chronic suppurative otitis media is characterized by persistent or recurrent purulent otorrhea in the setting of TM perforation. Usually, there is also some degree of conductive hearing loss. This condition can be characterized as active or inactive. Inactive disease is characterized by central perforation of the TM, which allows drainage of the purulent fluid from the middle ear. When the perforation is more peripheral, squamous epithelium from the auditory canal may invade the middle ear through the perforation, forming a mass of keratinaceous debris or cholesteatoma at the site of invasion. This mass can enlarge and has the potential to erode bone and promote further infection, which can lead to meningitis, brain abscess, or paralysis of the cranial nerve 7. Eustachian tube dysfunction, essential diagnosis is having ear fullness, fluctuating hearing, discomfort with barometric pressure change, and at risk for serous otitis media. The eustachian tube provides ventilation and drainage for the middle ear cleft. It is normally closed, opened only during swallowing or yawning. When the eustachian tube function is compromised, air trapped within the middle ear becomes absorbed and negative pressure results. The most common causes of eustachian tube dysfunction are diseases associated with edema of the tubal lining, such as a viral upper respiratory infection and allergies. The patient usually reports a sense of fullness in the ear and mild to moderate impairment of hearing. When the tube is only partially blocked, swallowing or yawning may elicit a popping or crackling sound. Examination may reveal retraction of the tympanic membrane and a decreased mobility on pneumatic otoscopy. Following a viral illness, this disorder is usually transient, lasting days to weeks. Treatment with systemic and intranasal decongestions such as pseudoephedrine 60 milligrams orally every 4 hours or oxymetazoline 0.05% spray every 8 to 12 hours combined with autoinflation by forced exhalation against closed nostrils may hasten relief. Autoinflation should not be recommended to patients with active intranasal infections, since this maneuver may precipitate middle ear infection. Allergic patients may also benefit from desensitization or intranasal corticosteroids such as beclomethasone, 2 sprays in each nostril twice daily for 2 to 6 weeks. Air travel, rapid altitude change, and underwater diving should be avoided during the active phase of eustachian tube dysfunction. Cholesteatoma is a special variety of chronic otitis media. The most common cause is prolonged eustachian tube dysfunction, with inward migration of the upper flaccid portion of the tympanic membrane. This creates a squamous epithelium-lined sac, which, when its neck becomes obstructed, may fill with discriminated keratin and becomes chronically infected. Cholesteatomas typically erode bone, with early penetration of the mastoid and destruction of the aciculator chain. Over time, they may erode into the inner ear, involve the facial nerve, and on rare occasions spread intracranially. Management, you need to refer to this otolaryngologist for surgical treatment. This diagram is an evidence-based to differential diagnosis and may be helpful to review. Now that you've completed the review of common ear problems, we will utilize this material for 1, case-based learning, and 2, as your quiz 1. See you in class.